This explainer is based on Autoimmune Inner Ear Disease, a vestibular physician's deep review, published by Australian Dizziness Clinics, available at australiandizzinessclinics.com.
Welcome, everyone. I'm so glad you're joining us because today we are embarking on a true masterclass for vestibular physicians, neurootologists, and audiologists. We're diving into the clinical escalation pathway for autoimmune inner ear disease, or AIED. We'll be looking specifically at management through steroids, steroid-sparing agents, and biologics. Now, AIED is rare, sure, but it occupies this strategically vital niche. It is one of the very few causes of progressive cochleovestibular failure that we can genuinely treat. But here's the catch. The therapeutic window is incredibly narrow. So mastering this exact management pathway is absolutely essential. Let's get right into it.
Here is our roadmap for today. We'll cover 1. Introduction to staged management. 2. First-line corticosteroid induction. 3. Steroid-sparing immunosuppression. 4. Biologics and targeted therapy. And finally, 5. Summary and key takeaways.
Section 1. Introduction to staged management.
The stakes in managing AIED literally could not be higher. Irreversible hair cell and neuronal loss accrues with every single delay, which means treatment has to begin on clinical suspicion. You have to escalate efficiently up this treatment pyramid. At the very foundation, we rely on rehabilitation. Hearing aids, cochlear implants, vestibular rehab, that underpins everything we do. Moving up, we hit corticosteroid induction, either oral or intratympanic. Now, if the disease proves steroid-dependent or keeps relapsing, we escalate to the third tier, which is steroid-sparing immunosuppression. When blanket immunosuppression just isn't cutting it, we move up to targeted biologics. And finally, at the very peak, for those strictly refractory cases, we reserve aggressive options like IV pulse steroids or IVIG.
Section 2. First-line corticosteroid induction.
Okay, the crucial point here is getting this induction regimen exactly right. We are talking about oral prednisolone at 1 milligram per kilogram per day, capped at a maximum of 60 to 80 milligrams. You have to maintain this full, high dose for 2 to 4 weeks. But what's really critical about this protocol is your exit strategy. Once that hearing response plateaus, you must initiate a slow taper over a further 6 to 12 weeks. Honestly, a rapid, hasty taper is the single most common, completely avoidable cause of relapse in AIED.
Mapping this out in the clinic, the corticosteroid trial is actually diagnostic and therapeutic at the same time. You get your baseline audiogram and speech discrimination, you start the full-dose prednisolone, and here is a massive clinical pearl, you must retest the audiogram at 4 to 6 weeks before any taper begins. You have to judge the response objectively, not just by how the patient feels. A responder is defined by a 10 decibel gain at 2 contiguous frequencies or a 12% or greater improvement in speech discrimination. If they hit that mark, boom, AIED is confirmed and you start your slow taper. If they don't respond, well, you need to revisit your diagnosis or get ready to escalate.
Roughly 2/3. That's the proportion of your AIED patients who will achieve partial hearing recovery or stabilization with this initial corticosteroid therapy. This right here is exactly why we treat early and aggressively. The mechanism is actually super fascinating. Glucocorticoids act directly on inner ear ion and fluid homeostasis. And you've got to remember, the magnitude of this early audiometric response is the absolute strongest single predictor of long-term hearing outcomes for your patient.
Of course, in the real world, not every patient can tolerate systemic oral steroids, and that's where targeted intratympanic corticosteroids come in. Delivering dexamethasone or methylprednisolone right through the tympanic membrane achieves high concentrations in the paralymph while totally bypassing systemic toxicity. Now, while the evidence base for this in AIED is mostly extrapolated from sudden sensorineural hearing loss, it is an incredibly valuable tool. It's an absolute game changer for steroid-intolerant patients, or if you're dealing with an only hearing air or a distinctly asymmetric disease presentation.
Section 3. Steroid-sparing immunosuppression.
As much as steroids are our first-line savior, we all know that long-term high-dose exposure is simply too toxic. The cumulative risk profile is brutal. We're talking hyperglycemia, hypertension, severe mood disturbances, gastric irritation, weight gain, and with prolonged courses, you're looking at debilitating issues like osteoporosis and avascular necrosis. Because a lot of patients inevitably relapse when you taper, this toxicity profile is exactly why durable steroid-dependent disease means we absolutely have to introduce a steroid-sparing partner agent. We simply cannot subject patients to repeated toxic steroid cycles.
But transitioning to traditional immunosuppression came with a pretty harsh reality check for the field. For years, everyone was super enthusiastic about methotrexate. But then, the pivotal 2003 multi-center randomized trial by Harris and colleagues threw cold water on the whole idea. They proved that methotrexate actually did not maintain the hearing improvement that was initially achieved with prednisone. This was a huge turning point. It basically taught us that blanket, non-specific immunosuppression ultimately disappoints when it comes to AIED.
Section 4. Biologics and Targeted Therapy.
Before we jump fully into the exciting world of biologics, let's quickly review the pragmatic bridging options we still rely on for steroid-dependent cases. Mycophenolate mofetil, or MMF, and azathioprine are frequently used because they're generally better tolerated. But please, take a look at cyclophosphamide at the bottom there. Because of its severe toxicity profile, specifically impacting the bladder and fertility, it is strictly, and I mean unequivocally, reserved only for severe, rapidly progressive, or vasculitic disease.
Okay, let's look at how biologics evolved in this space, because it brilliantly illustrates why we need precise targeting. Early on, tumor necrosis factor alpha inhibitors showed a lot of promise. But then, the Cohen pilot trial of etanercept was placebo-controlled, and it outright failed to show a benefit in primary AIED. It was just another strike against mistargeted suppression. But contrast that failure with the absolute breakthrough work by Van Boetis in 2014 using anakinra in corticosteroid-resistant disease.
Anakinra represents a total paradigm shift. It's an interleukin-1 or IL-1 receptor antagonist. What the Van Boetis trial showed was that in corticosteroid-resistant AIED, if your patient has an elevated inflammatory biomarker, specifically IL-1 beta, that biomarker actually predicts a positive response to anakinra. It results in measurable, objective audiometric improvement. This is monumental, guys. It frames AIED not just as some simple antibody issue, but as a cytokine-driven inflammatory process where innate immunity amplifies an adaptive trigger. This kind of biomarker-guided mechanism-targeted therapy is 100% the future of managing resistant disease.
Section 5. Summary and key takeaways.
If you take away anything from this explainer today, please let it be these 3 core clinical rules. Number 1. Treat early at full dose. Remember, that's 1 milligram per kilogram of prednisolone, and taper slowly, but only after you see an objective audiometric response. That early response is your best predictor of long-term success. Number 2, blanket immunosuppression, like we saw with the negative methotrexate and etanercept trials, generally disappoints. And number 3, precision is everything. Biomarker-guided IL-1 blockade is absolutely the most promising direction we have for corticosteroid-resistant disease.
What a journey through the management pathway, right? But our exploration isn't quite over yet. In our final explainer in this series, we cover prognosis, special populations, and future directions. Make sure you visit AustralianDizzinessClinics.com for the full review and companion materials. Before we sign off, I want to leave you with this thought. As we continue to map the precise cytokine drivers of inner ear disease, are we standing on the brink of an era where AIED isn't just managed, but entirely cured at the molecular level? Thanks so much for joining me today, and I'll see you in the final explainer.